Hey all, this is a good problem to have. I'm your host, Tyler Olson. It's great to have you here today, and I'm joined by one of your colleagues. This is Dr. Shamit Desai. He's an interventional radiologist. Thanks a lot for joining me today, Shamit.
Hey Tyler, thanks for the invite. Been awesome following you for all these years.
And you're part of Gotham Medical, right? Um, born and raised in Chicago. As soon as you said Gotham, I was like, oh, Chicago.
Yeah, yeah, and the inspiration was definitely the Christopher Nolan films. We're a bit nerdy about those. Partner and I started this interventional radiology private practice about 8 months ago. We've been lucky enough and fortunate enough to uh, be the stewards of two contracts and hopefully getting our third within the next couple weeks. So we have great partners. We're sort of considering ourselves a startup still here in Chicago, but it's great to see how the sausage is made, proverbially speaking, especially from the financial side of things. Getting a look under the hood is always nice, and we think we're doing the right thing by really trying to figure out what the value of physician services is in the field of interventional radiology.
Yeah, I mean, when you take on the role of ownership, the autonomy, the freedom to try to make what you want. I mean, in my own way, just in my field, like that's why I started my firm because I was like, I want to make it my own. I want to craft it for the people that I can serve, and I can see that you're trying to do the same. That leap
Right.
for doctors is very different than for planners like myself, as you know better than I do. So we could certainly talk about that. What led to me wanting to talk with you some months back was the astoundingly hard time doctors have with being able to understand how they are going to be paid.
Yes.
Like,
What
and
an interesting topic that is.
that is that is nuts. How like the more it it bothers me to no end.
Yes.
And I thought because especially you had mentioned that there's been some developments with your own practice that maybe you could speak to like the structure, like the structure of compensation as it stands today in in insurance involved medical care.
Yeah.
There's a lot to it. So like how how do you get paid?
Yeah. This
how,
is a this
or
is a
how
great question.
yeah, like I mean to the degree that you're willing to share.
Yeah, totally. I mean, this is such a complex question, right? And I think it's a conversation we need to have openly and transparently. Um, the first thing to keep in mind is that there are different sites of services and different models. So what I talk about is not going to be applied or be applicable to all physician models, right? There are physicians who practice on a cash basis or a concierge type service. This would not be applicable to them. Overwhelmingly, physicians in the United States are securing payments through payers, which would be CMS, that's Medicare, Medicaid, and insurance. Commercial payers, whether that be Blue Cross Blue Shield, Aetna, Cigna, all of the major insurance companies. Through those payers, services are rendered based on CPT code. Services are paid based on CPT codes and diagnosis codes, and there are certain limitations of what that payment amount may be. Medicare sets a rate every year um, based on the Resource Utilization Committee, the RUC, and that applies a certain amount of relative value units, what's called the RVU, to different CPT codes, diagnoses, and payments are issued via an RVU conversion. The, uh, the individual payers will decide based on the contract that they have either with a physician practice or with a hospital system, whatever the site of service may be, um, or whoever the client may be, what rate of Medicare they are paying. So different insurances have different rates of payment based on location, based on the perceived need in that community, or competition in that community as well. So large consolidated networks typically, and this is not true everywhere, large consolidated networks, multidisciplinary networks typically can demand a higher insurance conversion factor than or insurance rate per when compared to Medicare than from commercial payers than can like a solo practice. This is one of the uh, this is one of the many ways in which the solo practice is getting decimated in America right now. This is one of a multitude, myriad of ways in which solopreneurship is becoming much more difficult for physician owners than it had been in the past. I can tell you where we pivoted on that with Gotham Medical. If you think the listener might be interested in that.
Well,
Yeah.
before we dive into that, actually, before
Hmm.
we dive into that, because that is like, that's a slant. That's like a decision of autonomy and business development, correct?
Yes.
But for a lot of doctors, they haven't they haven't decided if they're going to do that, right?
Right.
And a lot of times it's because they may not understand they might be a little fearful of doing it, right?
Yep.
Um, and that's totally understandable. Um, so before we dive into that, could we start with like, because from your prior experience and what you've seen, what you observed around the field, how does someone who's not in that position of like designing or like negotiating a contract, they're just an employee and they're
Hmm.
going to get paid on based on RVUs. In fact,
Right.
I had a client that I spoke with a couple of weeks ago who is transitioning from a guaranteed salary to RVU based, and they're
Yes.
worried. They're worried that they're not going to be able to produce enough to match that guarantee.
Hmm.
So I was wondering if we could first speak to an employed doc, an employed physician who's like walking into a job and they're looking at a guaranteed salary and they're being told that after 24 months they're going to be RVU based. What should they be looking at to
Yes.
understand what's expected of them and what their realistic compensation will be?
I mean, that's such an important question. For historical context, about 15 years ago, 80% of physicians were private practice and 20% were employed.
15
Fast
years
forward
ago, that's it?
15 years ago. Fast
Man,
forward to today, and 80%. So it's flipped on its head, and now over 80% of physicians are employed in some way or another, whether that's direct employment through vertical consolidation with, you know, mega systems that are out there, or via private equity owned groups that do offer some equity share, but these are privately held companies. They are not on the public market. So now 80+% of physicians are employed. Um, our uh, our payment when we go from employment in the traditional sense of a salary-based employment to more of a productivity type model is a very, very common trend in physician, especially with physicians who are based in a clinical practice. The 2 year lead time is very typical in that type of employment model because that gives you enough lead time to build up your clinical practice. So we think about a general cardiologist, we think about a general surgeon, we think about a family medicine physician, a neurologist, people who can build their stable of patients, their Rolodex of patients over that 2 years and consistently get repeat visits while slowly increasing their visits with the support of staff that is provided typically for them via the system that they are employed by. All along the way, um, there are typically measures within the contract that also give them a step up, at which point they can ask for support. So if you hit a certain RVU threshold, then there will be a kick in where maybe there's an APP provided or a new physician hire. So all of these things are typically written well into the contract. The important question that you asked is once you're transitioning from a traditional W-2 that's salary based, you're getting the exact same amount every 2 weeks, uh, or every month via a W-2 salaried amount. Let's say that number is 250,000, right? For a physician, let's say pediatrician X, to then transition over to an RVU productivity type model. The really important thing to keep in mind here, and this is not denigrating anybody who is a non-physician. Um, there is just widget type mentality when it comes to physician time and physician hours that only other physicians can understand. As we all know, yes, the typical new patient visit may be 30 minutes. However, there are the occasional life happenstances and events. A patient may be 5 minutes late. There may be some, bad news in a staff member's life that you need to be a part of that just take up a little bit of time during the day. There has to be grace given within your RVU metrics that you need to factor in. The best way to do this is to take your RVU generation. I like to do over a 2 or 3 month period, average that out, and figure out what your monthly RVU may be. You can then interpolate that out to what your annual RVU might be, and only give yourself a step up that is reasonable to you. Not and that is your first point of negotiation with administration. if if the RVU target that they are setting for you is already at a percentage higher based on what your expected growth and productivity of your clinic may be, is outside of the scope of how fast you want to grow, you need to decide if this is going to be a productivity type model that's going to work for you. It's really important that you value your time and understand that each additional incremental RVU past your threshold that you're already at is going to be that much more difficult for you to factor in, given your personal life or other extenuating circumstances or the patient's extenuating circumstances, to actually fulfill those RVU goals. It's a really important question, and I have many physician colleagues who struggle with this every day.
Yeah.
The second factor to consider here is whether you're a proceduralist or whether you're a pure patient-facing clinician. Um, Certainly, those hours for a proceduralist can be just wildly off. One complicated case can throw off your whole day. One complication from a case, even a day, 2, 3 prior, can throw off your productivity numbers for the entire week. Productivity is significantly different for a proceduralist than it is for a clinician, in my opinion. Um, at the end of the day, and what my company is Gotham Medical and Physician Staffing Solutions, which is an independent contractor company for interventional radiologists. What we really try to emphasize is that the value that comes from physician care is that that you're a leader within the hospital system and that you are there, that you're available, and the replacement of a physician is actually a very high opportunity cost in this day and age for the site. So I think something that we don't emphasize early enough in our careers is that our value is extremely high to the system, and replacing us is often not worth it to them. So uh, making a job molded into what you want it to be, even if it's just a minor tweak, while being reasonable with those demands, is super important.
So there's a lot of work to do before agreeing to a job, isn't there? Like,
I would say so.
yeah, a lot of
Uh,
um, a lot of thought and analysis, right?
a lot of analysis on that initial contract. The the first contract you sign with a hospital, I like to think it as, I mean, I like to think of it as just the start of your relationship with anybody, whether it be a spouse, or someone who you might consider your next good friend that let enter your circle, or even just maybe someone who's going to be added to your golf foursome, right? There's a lot of vetting, and it's a two-way street. Um, as much as physicians are told, especially from large consolidated systems, that contracts are boilerplate and what they're offering you is what's going to be offered no matter what to anybody. I can tell you from personal experience, I can tell you anecdotally from many, many, many colleagues out there in the field, and I can tell you from doing a lot of personal negotiation with my contracts in Gotham and at PSS, that the first contract is never the last contract. And if you are signing that first contract, the people who've offered you that contract are doing high fives and backflips in the other room after you've signed it, because you should not be signing that first contract. I would actually, I have seen people just make a small 5 or 10. They actually like the first contract, but they got a sense of fulfillment just making a minor tweak on a relocation bonus or something like that, just to at least have shown the people that they have put in their time and vetted that contract. They've ran it through the proper channels, and they are willing to ask for a little more. It sets the table for a year or two down the road when you need to make another ask, when you need to make another adjustment, and you need to come up. They will remember, whoever you are negotiating with, that this was someone who did put in the time to and had it within themselves to ask us, for that little increase upfront.
Mm.
What's your advice to clients? I'm always so curious to hear from your perspective, because I know you start working in planning with physicians when they're as early as in residency, maybe even medical students for some of your clients. What is generally your advice for contracts and contract negotiation?
Yeah, I was gonna push back on you on something you said. Uh, so I will.
Okay,
um,
sounds good.
just because like I hear what you're saying and what I've heard other people say, and I'd like to get your take. There have been
Sure.
some who say like never accept the first contract,
Hmm.
but I've heard and I've seen firsthand administrators say or communicate this is the contract. That's it.
Hmm.
And what
Hmm.
that does is it leaves the doctor in a position of walking away and just saying, okay, you're
Yep.
telling me there's no negotiating here? Well, yes, there is. My negotiating tactic is walking away.
100%.
So, my question to you is if a doctor does that, what are the chances that it will result in the administrator coming back and saying, whoa, 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 hold up a second? Because, like most new docs coming out of
Yep.
training, they're, they've got the debt. They are just like, they need a job. And a lot of times, of course, this is related to like their interest. See, they lose leverage because they have an interest in some aspect of academic medicine. They
Right.
want like a research opportunity. They're looking for that career path, and the admin knows it.
That's leverage is the whole game, right? I mean, giving up too much leverage up front and
Mhm.
showing all your cards up front, in my experience and in my opinion, especially when you are the asset that the administrator 100% needs to fulfill their business,
Mhm.
is a losing play. I
Mhm.
mean, if my contractors told me every day, and I mean, I am so grateful for the people that I work with. I think that they are phenomenal physicians. They've all been vetted by myself or one of my colleagues. They're excellent at what they do. But if they told me up front, Shmeet, I will take $3,500 a day. Sounds great. Wonderful. That's all I'm looking for.
Mhm.
Or if they said, I can only take a job in Chicago. I'm willing to take whatever amount you're willing to pay me just so I have to stay in Chicago. The conversation is completely different. And this is actually why I think locums gives you the best sense of what the actual fair market value is of a doctor, because there's endless negotiation. It's all about negotiation. I mean, every contract is renegotiated every year because the market changes that dynamically, right?
Yeah.
Getting back to your point, I think it's a very valid concern, but you have to negotiate with your feet at some point, right? It
Mhm.
it really depends, and then the ball's really in your court at that point. If you don't reveal all your cards up front, and
Mhm.
you and you do indicate that this is just not quite where I need it to be, I'm willing to, I'm willing to play ball, but there are one or two additional things that I would need changed. It really depends on how far off that contract is from what you need. Now, is it far off on vacation? Is it far off on compensation? Is it far off on other benefits? Where it really depends, because sometimes one plate can be offset by another plate. So if
Hmm.
there's and typically benefits are not something that's able to be negotiated with very much because that's, based on the faculty foundation of that institution, and that's
Hmm.
sort of common amongst all physician employees within that institution. Benefits are typically not something that can be negotiated, but vacation and comp are typically the two things that can be leveraged one way or the other. We
Hmm.
have a formula at our hospitals, and within our groups for what a week of vacation is worth. And that's how we negotiate, not only with the client, the hospitals, but also with our contractors. And it's a very fair and transparent way of telling them where we're coming from and what their needs are. And we hope to make that conversation more transparent. We wish it was just more transparent up front.
Hmm.
I think that the conversations you're having are very real and very important. And so I'm really happy you pushed back a little bit there.
I don't know. I suspect that we're talking about at least two very different types of physicians here too, because someone that wants to go into academic medicine in in school and in training, their decisions and their relationships and even their resume details will clearly show the administrator what they're trying to prioritize. And so I think that the power of negotiation is just it right out of training. It's very, very challenging to overcome. The one
Hmm.
thing that I do tell new attendings to do, or soon to be new attendings to do, is hire a contract attorney.
Oh, for sure. Yes.
Hire somebody and go pay the $2,000 to do it. Like
Yep.
I
And that contract attorney's name is not Claude or ChatGPT.
no
Like
heavens
like a
no
like a
no
real person. Yeah.
right yeah
Right.
like I mean I've had a lot of great experience with like Resolve, for
Yes.
example.
Hmm.
Kyle Clausen and his team, they do a great job there.
Yep.
um and there are others, but
I think different. It's a really good point, and I think there are different preferred vendors for different specialty societies. So I know the Society of Interventional Radiology. They started something interesting recently. I sit on the Private Practice Advisory Committee. There are about 15 of us nationally,
mhm,
and what came out of the Private Practice Advisory Committee was a preferred vendor directory,
mhm,
and it's people who are actually tied into the society in some way or the other. These are people who have previously given lectures for the Business Institute of the society. And I know this is done elsewhere, like, with cardiology societies, family practice, pediatrics. So I think societies, if there are preferred vendors, I think Resolve is phenomenal, by the way. I've had a lot of colleagues who've used that service and said it was great.
mhm.
But what you said is 100% right, Tyler. I mean, having someone with expertise in contract law, reviewing and seeing where it's reasonable to push back on,
Mhm.
with employers is super super important.
Yeah, because you mentioned like the two factors that you can possibly move the needle on, and that's vacation time and the comp time. But a lot of
Right.
doctors, they don't know where to begin. You could go and you could pay for a compensation report from MGMA or something, but
Right.
I think it's very challenging to know what to do with that information.
Correct.
And I know, like, fellows and residents, they don't have a bunch of money, but this is one of the things where I don't say this easily, but putting it on a credit card, I almost say like that's a good idea because
Yeah.
if we're talking about, I don't know, like the fee ranges, it could be anywhere from like 700 to 2,500 bucks, I think.
Right.
But let's say it's $2,000, and how much effort or how much leverage can a professional give you to be able to overcome that cost over the next 3 years of the first contract?
I mean, so it can be huge. Not only can it be huge in entering a contract, right? And I don't want to go too far off on a tangent, but I've had colleagues who are exiting a contract, and
Mm-hmm.
the contract attorney that they already had a established relationship with on the entry to that job
Mm-hmm.
helped them out so much, and already had notes on their contract when it was time for them to exit the contract. under
Hmm.
terms that were not exactly specified, or may have been left somewhat nebulous in the terms. I know a colleague who had a 120-day notice to give. They needed to leave within 90 days for the next employment opportunity they were headed towards. It became a bit sticky because the former employer was giving a lot of pushback for how long it would take to hire and recruit someone else,
Hmm.
despite being overstaffed at that time.
Yeah.
That is when their contract attorney came back in, and they detailed it out to me. This was a former partner of mine. They detailed it out to me in real time, and it was really impressive how quickly the communications came in back and forth between their legal advisor and legal from my former employer. It was very, very handy at that point. And she said the fees were not as bad because there was no new contract being written. It was a series of emails back and forth. At the
Mm.
end of the day, she got what she needed, even in a difficult state to traditionally practice in. So this was that was a win, and certainly worth the several hundred or few $1,000s it may have cost to get her out of the job that she needed to.
Yeah. Yeah, that's a good point. The add-on value of a continuous relationship, someone that
Yes.
you've worked with in the past. It's good to have that continuity. I think in summary then what I'm seeing as far as like how to negotiate comp for someone in like an academic institution is hire an attorney so you get the highest rate that you can for like what you're doing so that you're not just accepting the baseline salary that they offer you.
Yeah.
However, in a private practice setting, um, I suspect that it's a little bit different. I mean, if it's a private practice, it's going to be an employee role. I suppose that's a very
Right.
niche. But eventually, a lot of docs that go that route, they want to become an owner themselves. So like, how do they negotiate? How like I mean,
Yes.
I guess it's a similar process with an attorney, but do you think that they can push back? Do you think that they can push harder?
So I think there are many different ways to skin a cat when it comes to private practice, right? These are typically not there are many ways to practice in private practice. There's a lot of outpatient based care that's not formally affiliated with hospital based medicine, right? Um, Standalone multidisciplinary networks, standalone even solo offices, and in those roles, you're paying yourself, right? You are taking on all the liability, but you're also formulating your own payroll. You're also paying out everybody else and taking on all the overhead. So that's one way to practice in private practice. The way we do it, I'll draw off the example of Gotham. We offer physician service agreements to hospitals. We work with hospitals, and we have a very simple formula. We see what their accounts receivable were for our for our specialty for the year prior. We use that as a baseline for how we might structure our contract just to see what the already existing model is for interventional radiology in that hospital.
Hmm.
Because we think we will add value to service, we take a list of all of the CPT codes that they billed for in interventional radiology in the year prior. We then add in a pro forma what we think reasonably, and we're always conservative on this estimate, what we think we can add to that service line over a 12-month prorated, and then we add 15% because we consider ourselves a premium service.
Hmm.
So we have a very defined formula of what we think a premium standalone interventional radiology department is worth in a hospital because you cannot run trauma service, you cannot run surgery, you cannot run urology, you cannot have a hematology oncology practice, and you can't have a lot of other bailout services, including just getting adequate patient throughput through your hospital, so the ER and the floors for your general medicine patient without having interventional radiology there. We think that's somewhat unique for interventional radiology, but with all of our contracts, we do leave in a productivity option after year two, just like we were talking about with the academic side on the previous half of the conversation.
Hmm.
So we leave in the optionality of looking under the hood, seeing exactly where our trajectory has been from when we started to the end of year two. If we've achieved a point that makes sense we then negotiate a rate for productivity, and we're not there yet in our contract, but we then are able to negotiate a rate where we do a share of the global billing with an adequate baseline compensation for the physicians in that contract. So we need the threshold to be low because our services render so much uh, back end compensation for the hospital. When our services are performed in the hospital, even if you're in part of a group that bills for themselves, it is the hospital. It's the technical side of the compensation that actually makes the majority of money. And going all the way back to the beginning of your of this recording, when you asked how doctors get paid, when we were talking about the CMS and them distributing via RVU, the RVU is divided further into the physician professional component, which is modifier 26, and
Mm-hmm.
what's called the technical component. The technical component is given to the site of service for the machines, for the staff, for, the IV poles, for supplying all of those things. So if you are working for a hospital, the hospital is not considering that RVU as part of your professional RVUs that you are generating. The RVUs that a physician is generating is the professional, the modifier 26, the professional component RVU, which is always a fraction of what the technical component RVU is on a global payment. What we do when we come in from our practice, which is why our practice is a little bit unique in the space, is we have the hospital base globally for RVU. They bill the whole thing, and then our physician service agreement has us being paid a reasonable amount based on the overall global reimbursement that they are getting from payers.
That's good that you're taking that, like you're cutting through the thicket of of how hospitals get paid, and that way you can put yourself in a position to better advocate for like what should we be paid for, like the work that's being done and the revenue that's being produced. That's really good. Um,
Thank you.
okay. Yeah. So good for you. That's fantastic. Would you be up for a part two?
I would definitely. Yeah, this has been a really fun conversation. Thank you.
Okay. Because I'd like to delve into further like how you got to where you are now with Gotham
Mm,
Medical,
hmm.
because a lot of people that I talk to and who I think are listening to this are
Yeah.
thinking about how do I do what you're doing?
Yes.
Whether it's in radiology or and their version of it in another specialty, whatever that might happen to
Yeah.
be. Um,
And
so
I'll give you the brief preview for that conversation. It was because of my experience. It is due to my experience in locums and independent contracting and understanding how these negotiations might work. So I did a
mm,
lot of direct contracting, and then I started my own contracting company with two colleagues,
hmm
Physician Staffing Solutions, which it's
hmm
interventional radiology based only. Those contract negotiations and seeing what the needs are from the other side,
hmm
seeing what the administrators, how they process their needs to a vendor, it made a lot of sense to me, and it changed the narrative of how I looked at it. Um, Traditionally being an employee for 8 years before that.
yeah,
So a lot of times there's just a disconnect between how the two parties are looking at the services that both need to fulfill the goals of taking care of the patient that's coming into that hospital or that clinic.
yeah, okay, yeah. No, that'll be interesting to delve into more. Thank you
Sure,
for expounding on some things to start with today. It was a fruitful conversation, and
I appreciate that.
we'll yeah, we'll get on the books to schedule it so that we can keep talking, because I think a lot of doctors would benefit from um, what you've learned through
Thanks a lot.
your experience. So
No,
can't wait.
I appreciate that.
Yeah, yeah. All right.
This was a really fun conversation. I really I was looking forward to it, and it definitely delivered.
Oh,
So
good.
thank you,
Yeah,
thank you for
yeah,
the insightful questions.
yeah, yeah, for sure. All right, Shamit. Well, thanks everyone for listening today. Um, Shamit and I are going to be talking again, part two, talking more about the trajectory into private practice and making it a success. thanks again, man, and we'll talk soon.
Much appreciated. Take care, Tyler.